Why does one blood collection tube use heparin while another uses EDTA? Not all blood thinners do the same job. Different laboratory tests require entirely different chemical environments to succeed. Today, we are targeting the green top tube. We will look at what heparin actually is and why it serves as the foundation of stat clinical chemistry. We will also look at how specific pre-analytical errors, like drawing from a contaminated IV line, can completely compromise a chemical specimen before it even reaches the laboratory. By the end of this lesson, you will be able to trace the specific biochemical pathway that allows the green top tube to function and identify the precise handling errors that can invalidate its results. In clinical laboratory medicine, the green top tube is the primary vessel for clinical chemistry and urgent stat laboratory tests. Its active additive is heparin. But heparin is a naturally occurring anticoagulant. It doesn't artificially extract elements from the blood to stop coagulation. Normally, blood clotting relies on a slow, sequential cascade of protein factors activating one another until they form a physical fibrin web. Your body regulates this cascade using a protein called antithrombin, which acts as a natural brake pedal against active clotting factors. Heparin binds directly to antithrombin, supercharging it. This instantly accelerates antithrombin's ability to neutralize clotting enzymes, and clot formation freezes immediately. This operates very differently from anticoagulants like EDTA or sodium citrate, which work by physically chelating or removing essential elements like calcium from the blood. By supercharging a natural regulatory protein rather than chelating elements away, heparin preserves the exact in vivo chemical state of the blood for accurate chemistry testing. This chemical difference dictates hospital workflow. A red tube yields serum, while a green tube yields plasma. To get serum, blood inside a red tube must actively clot, requiring 30 to 60 minutes sitting on a counter before processing. Because heparin immediately prevents clotting, blood inside the green tube remains fluid as plasma, bypassing the waiting period entirely. In an emergency department where diagnostic data is needed immediately, this plasma can be centrifuged and analyzed the moment it arrives in a laboratory. Physicians rely on this immediate turnaround for critical stat tests, specifically comprehensive metabolic panels, kidney functions, liver enzymes, and cardiac markers. It is also strictly required for ammonia testing. Ammonia levels rise rapidly as blood cells metabolize, so the sample mandates heparinized plasma that must be placed on ice and tested within 15 minutes to prevent cellular degradation. Bypassing the biological speed limit of coagulation makes the green top tube the primary requirement for urgent stat chemistry testing. However, heparin is an acid. To function as a stable additive inside the vacuum tube, it must be paired with a salt. Laboratories rely on two dominant heparin salts, lithium heparin and sodium heparin. Lithium heparin is favored for routine chemistry. Because lithium is rarely an analyte of interest, it won't interfere with accurately measuring a patient's standard electrolytes. But there is a strict contraindication for lithium heparin. If you use it to measure therapeutic lithium drug levels in a psychiatric patient, the additive causes a massive false high, destroying the accuracy of the test. In those specific cases, you use sodium heparin. Because it lacks lithium, it is reserved for measuring lithium levels, as well as highly specialized tests like cytogenetics, HLA typing, or flow cytometry.
But sodium heparin carries its own strict limitation. The inherent sodium inside the tube will falsely spike a patient's routine sodium electrolyte results. Selecting an incompatible salt creates a chemical artifact in the specimen, directly distorting the physiological values the physician needs to make an accurate diagnosis. The order in which blood tubes are drawn is a strict chemical sequence designed to prevent additive carryover, not a random choice. Light blue comes first to protect coagulation factors. Red follows, containing activators to actively force clotting. Lavender comes last, utilizing EDTA to protect cell morphology. The exact rule for the green top tube is that it must be drawn after serum tubes, like red or gold, but before EDTA tubes. Drawing a green tube before a red tube invites a catastrophic consequence. As the needle punctures successive stoppers, trace heparin cross-contamination occurs. That trace heparin will completely paralyze clot activators in the red tube. You are left with a ruined, fibrin-clogged sample that jams automated laboratory analyzers.
Everything a microbiologist needs in one app. lab tools, calculators, microbiology updates, and study resources. Download it from the link in the description.
Understanding heparin's mechanism clarifies the logic of the order of draw, transforming it from a memorized sequence into a necessary safeguard against additive carryover. Immediately post-collection, the physical handling of the tube by the phlebotomist is just as critical as following the chemical sequence. Exactly 8 to 10 gentle inversions are required to properly distribute the heparin into the blood without damaging the cells. Vigorous shaking causes hemolysis, physically breaking the red blood cells. When cells rupture, they spill intracellular potassium into the plasma, rendering the chemistry results completely useless. Finally, consider this practical case study. A green top sample is drawn from a hospital bed IV line, and the resulting lab data looks bizarrely unusual. Hospital IV lines are frequently flushed with high concentrations of heparin to keep the plastic tubing from clotting. If a nurse draws directly from a heparin-flushed line without drawing a proper discard volume first, massive heparin contamination occurs, skewing coagulation times and electrolytes entirely. Even with the perfect tube and the correct salt, poor physical handling or improper IV collection protocols will completely invalidate the specimen's chemistry. To consolidate this, here are the 10 critical must-know facts for MLT exam preparation. 1. Heparin prevents clotting by enhancing antithrombin. 2. It yields plasma for stat testing. 3. Lithium heparin is standard for routine chemistry panels. 4. Sodium heparin is strictly for specialized tests. 5. Never cross-contaminate salts. No lithium heparin for lithium levels, and no sodium heparin for sodium levels. 6. Order of draws dictates green comes after serum but before EDTA. 7. The tube requires exactly 8 to 10 gentle inversions immediately after filling. 8. Hemolysis falsely elevates potassium. 9. IV line draws require a discard tube to prevent contamination. 10. Always verify analyzer requirements with your laboratory SOPs. Heparin enhances antithrombin to keep blood fluid, yielding plasma so stat tests can run without waiting for a clot, provided your salts, order of draw, and collection methods are perfectly executed.
MLT exam must-knows. We are bringing it all together now with the ultimate rapid-fire review of everything we've just covered for your exams. Lock these first 5 points into your memory. 1. Heparin acts by supercharging antithrombin 3. 2. Lithium heparin is your absolute go-to for routine chemistry and stat panels. 3. Sodium heparin is for cytogenetics, flow cytometry, and lithium drug levels. 4. Green tubes yield plasma, meaning fibrinogen is still present. And 5. Order of draw is always after serum, but before EDTA.
And here's part 2. Point 6. Always mix with 8 to 10 gentle inversions. 7. Hemolysis completely ruins potassium accuracy. 8. IV line contamination requires strict clearing protocols. 9. Heparin is strictly contraindicated for PCR testing. And 10. Green tubes completely eliminate the 30-minute clotting wait for stat processing. These points are exactly what transform you from a student into a highly competent lab professional.
So let's do a quick recap. What is in the green tube? Heparin. How does it work? It supercharges antithrombin 3. Why do we use it? For stat plasma with 0 wait time and no fibrin. And what goes wrong? IV contamination, hemolysis, and PCR inhibition. If you found this lesson useful, subscribe and follow for more MLT topics, laboratory techniques, hematology, microbiology, clinical chemistry, and exam-focused content. Before you go, ask yourself, the next time you pick up a simple plastic green tube, what invisible chemical reactions are you about to set in motion that could dictate a patient's diagnosis?
Subscribe and follow for more MLT topics, laboratory techniques, hematology, microbiology, clinical chemistry, and exam-focused content.